Welcome, everyone, and thank you for joining us today to the HSC Office for Diversity, Equity, and Inclusion Women's History Month event. I'm Dr. JP Sanchez, and I serve as the Executive Associate Vice Chancellor for Diversity, Equity, and Inclusion here in the Office of DI of the HSC. On behalf of all of us at the HSC Office of DI and Vice President Dr. Romero Leggett, we'd like to thank you for making time to join us today. For those who could not be here today, this presentation will be recorded and posted on our HSC Celebrations website. Before we begin, I just wanted to go over a few housekeeping items. We'll be using a Zoom webinar format that does not allow participants to address the panelists directly, but rather through the Q&A function. The chat feature is not available. Please place your questions in the Q&A box at the bottom of your screen. We will try and address as many as we can by the end of the presentation. You can see the panelists, but the panelists cannot see you. Please also take a moment to complete the pre-assessment in the chat box. This will help us understand your interests and reflections during this month. With that, thank you so much for joining this particular session on reproductive healthcare in a post-Roe America. We're truly honored to have Chair and Dr. Espey share with us all of her great work over decades of leadership, not only for the state, but for the country. Thank you, Dr. Espey.
Yes, thanks so much, JP. Yes, decades. This has been my career focus. It is a topic that I'm really passionate about. So really pleased to be speaking to you today on this topic. And I just, want to start by saying this is, Women's History Month, a wonderful celebration. I am going to use the word women throughout the presentation, but I do want to, just be cognizant that not all people who can become pregnant are women, and to know that this is a convention, but very, very, very much feel inclusive towards everyone. And I just want to do a very brief land acknowledgement. The University of New Mexico, which is where I am right now, sits on the traditional homelands of the Pueblo of Sandia. The original peoples of New Mexico, Pueblo, Navajo, and Apache since time immemorial have deep connections to the land and have made significant contributions to the broader community statewide. We honor the land itself and those who remain stewards of this land throughout the generations, and also acknowledge our committed relationship to Indigenous peoples. We gratefully recognize our history. This is our UNM land acknowledgement. So thank you. And then finally, I want to thank, my team and, my complex family planning team. Those are the 6 of us who provide complex family planning and abortion care here at UNM, along with our family medicine colleagues who also provide that care, but also my entire department. The surge of patients that we're seeing that I'm going to talk about in just a minute. It touches our entire department. And indeed, I want to thank beyond our department, the institution, which has also really been affected by and that have stepped up for some of the challenges that we know our patients, particularly from Texas, are experiencing and have really stepped up to help our patients and also us as providers. So lots of gratitude. Okay, I don't have any financial disclosures, but I will disclose that, like my professional organization, the American College of OB/GYN, I agree that abortion is essential health care, and that abortion is part of comprehensive, evidence-based reproductive health care. And there are major consequences when abortion care is made illegal. We're already seeing some of those. So the objectives of the talk are to explain the context and the current status of abortion care access in the U.S., to understand the impact of restrictions both on clinical care and training, and also to describe challenges providing care on the front lines in a surge state. And I do want to acknowledge that abortion has a moral dimension. And Justice Blackmun, who wrote for the majority in Roe v. Wade, acknowledged this. And we talk about this a lot. In fact, our conversation in the U.S. really tends to focus on the morality of abortion. And the way we feel about abortion is very much influenced by our upbringing, our religion, many of our own experiences. And of course, all of the ways that people feel about the morality of abortion are valid. But what I'm not going to actually talk about the morality of abortion today. And I think as providers and as healthcare professionals, we are held to a standard of putting our patients' interests first. And so this talk is actually focusing on what, the consequences for patients and for public health when abortion is illegal. So speaking of Roe v. Wade and Justice Blackmun, this is a picture of him. He was the justice who wrote the majority opinion. He was a Republican appointee appointed by President Reagan, he was appointed by Nixon, and he wrote for the majority in Roe v. Wade. This has been the law of the land for almost 50 years until it was overturned on June 24th, 2022. So what happened after the Roe v. Wade was the decision is that we saw a very large decrease in maternal mortality. And this is 1973 right here. So, other forces, brought to bear to decrease this maternal mortality rate, like, for example, antibiotics, aseptic conditions. But Roe v. Wade was responsible for a very large decline in mortality from septic abortion. And you can see that this rate went down very shortly after after Roe, and the death from abortion in the United States, where it has been legal, has been exceptionally low. In fact, lower than many other procedures like colonoscopy or plastic surgery, or many other far less regulated procedures than abortion. And back when Roe was overturned, when Roe became the law of the land, there was actually not a lot of pushback initially, and certainly not by the provider community, by the physician community, because so many physicians across many specialties had seen patients suffering from septic abortion. And this was a qualitative study of pre-Roe physicians and their experiences before Roe. And for example, Dan Michel, who was chair at USC for years and years, said, "I'm telling you, it was really an awful situation. It touched me because I'd seen young, healthy women in their 20s die from the consequences of an infected, non-sterile abortion. Women would do anything to get rid of unwanted pregnancies. They'd risk their lives. It was a different world, I'll tell you." And I think that really captures, the huge relief in the medical community when abortion became legal, and unsafe, coat hanger abortions essentially went away. And so since that time, the U.S. abortion rate has been going down. So you can see again, it went up pretty dramatically shortly after Roe, and then it's been going down for since that peak in the early 1980s. And recent, this is 2017, but looking at 2020 data, it's essentially the same. It's around 13.5 to 14 per thousand. So it has gone down a lot. What about abortion mortality globally? Well, that's a very different story. And about 10% of maternal deaths globally are from unsafe abortion. So what's unfortunate about this, and this is data from Doctors Without Borders, is that the world has made significant progress on most of the other causes of maternal mortality, which are infection, high blood pressure, and severe bleeding, but not on abortion. Again, because there is so much pushback around this procedure. So, many women harmed, many women die every year from the consequences of unsafe abortion. And about half of the world's women live in countries, mostly low-resource countries, where abortion is illegal. So this is what happened after Roe. I said immediately, in the medical community, there was initially very little pushback. But if, again, we look at Roe in 73, since the time since that decision, there has been a raft of legislation imposing abortion restrictions and other Supreme Court decisions that weakened the initial protections of Roe v. Wade. And you can see that really picked up in about 2009 with, many restrictions decided just in that last period of time. And that is because those who oppose abortion, anti-abortion activists, worked together and became very sophisticated in techniques to outlaw Roe, and so to outlaw abortion. And so that is what we've seen in terms of the culmination that just occurred in 2022 with the reversal of Roe. So, who gets abortions? Well, this is also an equity issue. This is from a recent paper in the American Journal of Public Health that basically looked at the typical patient. The majority of patients are in their 20s. They're low income. They're unmarried. They're non-white. They had graduated from high school. And most of them are mothers, had at least one previous birth, and also had a religious affiliation. Reproductive justice is a concept that looks not just at unplanned pregnancy, but it looks at a much more global picture of reproductive health, one in which women can choose to be pregnant, not be pregnant, and then parent the children that they have in a safe and secure environment. Well, the women that are most affected by abortion and by illegal abortion are often low-income women of color. So the reversal of Roe was a very big deal for the country, but in terms of what's affected us in New Mexico, that story actually started a year earlier in September of 2021, which is when Texas Senate Bill 8 was passed and went into effect, banning virtually all abortions and medical counseling and support related to abortion after 6 weeks. So the game changer for New Mexico was not Roe, although Roe continued the issues that we've been dealing with since Espey 8, but it was really September 1st, 2021. What was Espey 8? Espey 8 was legislation like no other, in that it prohibited abortion after detection of fetal cardiac activity. There were exceptions only for medical emergencies, and we'll come back to that concept because medical emergency is not defined in Espey 8. It bans aiding or abetting a prohibited abortion. And here's what's really different about Espey 8. Unlike the normal enforcement mechanism for laws that restrict abortion, which go through the state, these are enforced through private action, where any regular citizen can sue anybody who they feel has aided or abetted a prohibited abortion. They don't have to have any particular evidence to that effect. They simply, if they feel that somebody has aided or abetted, they can sue that person. And then that person is liable for $10,000 in damages to anyone who successfully sues, as well as court costs and legal fees. If it's found to be a frivolous suit, and again, this hasn't been tested, at least not all the way through the process, if it's found to be a frivolous suit, there is no recourse for the person who is sued. So it's this enforcement mechanism is particularly draconian Because, and you'll notice here that it's not about the person who it doesn't criminalize the person who accesses the abortion. It's anybody who aids or abets. So a provider, a cab driver, a sister, a dorm mate, like literally anybody. And so the law was designed to create fear, confusion, and chaos, and it was very successful in doing that. And so, to look at the impact on New Mexico, this looks at the year September to December 2019, and then compares it to September to December 2021, so that same period of time in the year before SB 8 and then the year of SB 8. And so out-of-state abortions obtained by Texas residents in that period of time, 514 before SB 8 and 5,574. So the impact was immediate. And this was in the first few months after SB 8. This is from a group called the Texas Evaluation Project that looks at contraception and abortion in border states, and found that 27% of patients went to New Mexico, and then 45% went to these other states. Well, we're going to look at a minute at what happened to these other states. This is before the reversal of Roe, but after SB 8, when these 6 states bordering Texas were open and had open clinics to provide abortion care. That changed dramatically. So how do we get patients? Well, patients, of course, have found centers in New Mexico where they can access abortion care. But this also left the medical community in Texas in a very challenging situation. So we've gotten many calls from maternal fetal medicine specialists who are caring for patients who have very high-risk medical conditions or who have pregnancies affected by fetal anomalies. They could not refer their patients for abortion care, but developed this code language. We've heard that the sunsets are beautiful in New Mexico, which, when you think about, medical professionals in 2021 or 2022 having to refer patients in this oblique kind of way, patients who really needed the care, that's been very problematic. Now, what about New Mexico? We're a very large rural state. We have a very small population, only 2 million people. And at the time, when SB 8 passed, there were only 3 centers in New Mexico that provided procedural abortion. And those were all in Albuquerque. Now, there was medication abortion available in Santa Fe and down in the southern part of the state near Las Cruces, but procedural abortion was limited to Albuquerque. So this is what happened to our volume after SB 8 passed. We saw a 65% increase in volume. Our wait times went to, from 1 day to 2 to 3 weeks. And then we saw a 5-fold increase in second trimester patients. So what's the difference between first trimester and second trimester? Second trimester abortion care requires more time, often, a full day or 2 days. Although abortion is very, very safe in both the first and second trimester, there are more risks in the second trimester, particularly for patients with medical complications. So this has been, really challenging for patients. Why have we seen such a huge increase in second trimester patients? Because it's so hard for patients who live in Texas, which, is frequently anywhere from 4 to 16 hours away. Relative to traveling in a car or getting the money for air travel, so many barriers that were already in place for accessing abortion care has now pushed many people into the second trimester. So this is sort of a graphic representation of what we saw. These are medication abortion. This starts in November of 2020 before Espey 8. Here's where Espey 8 occurred. This is sort of a volume graph. So medication abortion, this is abortions below 15 weeks. And red is abortion over 15 weeks, which is second trimester. And this is where we saw an enormous increase both in volume and in complexity. We also became famous overnight because so many patients came to us. We've been, our wonderful complex family planning team has been interviewed in papers nationally, and this is ongoing. These are just a few stories, and we could, add several every day. We had a patient with a lethal anomaly, diagnosed at 11 weeks, a prior C-section. She presented at 17 weeks because she was unable to access, she was unable to get to us before then. She had high suspicion for a condition called placenta accreta. She was transferred to inpatient care, had an abortion and a hysterectomy complicated by massive transfusion. A scar ectopic. These are pregnancies that implant in the scar. She was refused care unless she developed heavy vaginal bleeding. This gets back to what's a medical emergency. A patient with a self-managed abortion in Mexico who presented with essentially a septic abortion. And finally, a patient with multiple comorbidities who had an abortion in New Mexico. An IUD was placed. She went back to Texas, was concerned about her IUD. Her doctor would not see her because she had had an abortion, even though this condition had nothing to do with the abortion. And again, there's that law that created so much chaos and confusion that it's had a ripple effect far beyond abortion care. So that was Espey 8 for us. And then came the reversal of Roe v. Wade in June of 2022. And I will say that health organizations that have previously been reluctant to be, very out-front on the issue of protecting the legality of abortion have really stepped up. The American College of OBGYN, I mentioned. The American Medical Association has never been vocal about this issue and has really been stepping up as well. The American Public Health Association, the World Health Organization, numerous health organizations who understand the dire consequences of making abortion care illegal are becoming more vocal advocates. Well, what about the consequences? This is 1 month post-Roe. And this is from the Guttmacher site, which is a think tank and a research institute focusing on contraception and abortion. 1 month after Roe was reversed, at least 43 abortion clinics across 11 states stopped offering abortion care. And this at the time were the states that had total bans and no clinics: Alabama, Arkansas, Mississippi, Missouri, Oklahoma, South Dakota, and Texas. So again, Texas had already gone down with Espey 8, but it had an immediate and devastating impact on the ability to access care. This is a study, I won't go into it, but a condition that occurs where membranes rupture very early in pregnancy, where there is no hope that the fetus could actually survive to viability. Traditionally, we have always offered patients induction of labor or procedural abortion care, and no longer in Texas can that occur. So since Espey 8, 2 large hospitals in Texas looked at their maternal morbidity, patients who developed sepsis or hemorrhage, based on the inability to offer intervention. So you can see in the expectant management group, there was twice the maternal morbidity than there was in those who were offered immediate intervention. So again, there is now a body of data that is being collected to show the harms of not allowing standard evidence-based medical care, and we're beginning to see that in studies. Now, because of the intense politicization of these issues nationally, many, not some, have questioned, what does the threat of death have to be? This is getting back to what's a medical emergency. Now, each state that has restricted abortion has a different definition, but Texas's is one of the most challenging. But most of them are vague enough that they have people, really questioning how bad does it have to be? How sick do you have to be in order for this to be considered to be legal in whatever state? And that question is just part of the chaos and confusion. Well, this is a qualitative study that interviewed 20 patients from Texas who sought care out of state and what they had to say. Here's one. I knew how dangerous it was for me to get on a plane and go get an abortion, she told us, but I knew that it was still the safer option for me than sitting in Texas and waiting, and I could potentially get sicker. So this is a patient that would have been that would have met the criteria for the study that I just talked about. Another, if you labor on the plane, leave the placenta inside of you, you're going to have to deal with a 19-week fetus outside of your body until you land. And this was a patient who received a diagnosis of spina bifida and trisomy 18. These are lethal anomalies, like a fetus that could not live. She was shocked that her physician would not even inform her about termination options. When you already have received news like that and you can barely function, the thought of then having to do your own investigating to determine where to get this medical care and to arrange going out of state feels additionally overwhelming. So what are hospitals doing? Well, I've got some good friends in Texas, and what they're doing, and this is happening nationally, is they're getting, and this is advice from the Society of Maternal Fetal Medicine. Maternal fetal medicine are high-risk pregnancy doctors who have also really stepped up in helping promote access to legal abortion care. That you get your hospital folks together with providers and your legal department, and you define for your hospital system, what will meet the requirements of the law to allow you to take care of groups of patients. So you're not doing a one-off for every single patient who comes into the facility that may be experiencing medical complications. This is from a Florida hospital. Where they did just that. They put together a list where, at least if patients had these conditions, bad kidney disease, maternal cancer, unable to receive optimal treatment in pregnancy, these kinds of conditions, that their team as a whole agreed they would not need to get individual approval to provide abortion care for. But I think this shows just the spectrum of medical complications that for which abortion care is often the best kind of care. Similarly, the U.S. government has been helping, and this was an executive order from the Biden administration to protect access to medication abortion, to specify that EMTALA extends to emergency abortion care. And protects access to other kinds of reproductive health care. EMTALA is an interesting one. So if a physician believes that a pregnant patient presenting is experiencing an emergency and that abortion is the treatment necessary, that it's required that the physician provide that treatment. And this says 2 courts ruled on this EMTALA provision, Texas it basically sued in order to not have to comply with this regulation. So what about training? About half of OBGYN residents, and this doesn't even talk about family medicine residents, half of OBGYN residents are in residencies that are now highly restricted and no longer have the ability to receive training within their state. There's been a lot of press about this. 45% of residency programs are in those states. And since 1995, the ACGME has required that OBGYN training programs provide an opt-out experience for abortion training, meaning that it has to be set up. Individual residents can opt out of it, but it has to be a comprehensive part of the comprehensive curriculum. And this is the requirement. Programs must provide training or access to training in the provision of abortions. And since that occurred in 1995, and since there was a program that was funded through a private anonymous donor to support programs like at UNM, we received funding from this donor many years ago to have to help with our ability to train residents in abortion care. The majority of residencies now provide this abortion training within their residency program. That is now really under threat. And our college, the American College of OBGYN, is working on a number of ways to help residents who are in restrictive states to be able to access that training, either out of state and through simulation-based techniques and through didactics, but still with the requirement for clinical care. So we're becoming a nation of restrictive and protective states. This is a map that's put together by the Guttmacher Institute that I mentioned previously. And of course, this landscape changes all the time. It's changed quite a bit since the website first went up. And, basically protective states are in green. And the most protective states are in dark blue. Oregon is a standout, and then the most restrictive states are in red. So this is a comparison of New Mexico, and we just became more protective. I'm really thrilled, and we'll just mention that our legislative session just finished, and two really important pieces of legislation were passed. One, HB 7, prohibits municipalities like some municipalities or local governments in the southern part of the state outlawed abortion. Well, this is a law that basically does not allow local ordinances to take priority over state law. So that will no longer be able to be done. And it prevents discrimination both against abortion care or other reproductive health care, as well as gender affirming care. SB 13 was another very important law that prohibits sharing of personal and medical information related to people from out of state coming into the state. So it prevents their personal information and providers' information. So it's a law that will shield abortion providers in New Mexico and allow them to continue to care for patients from out of state. Late breaker, you've probably heard about this. We in the reproductive health community have all sort of been on the edge of our chair waiting to see if a judge in Texas will bar the use of mifepristone. This was a lawsuit filed by the Alliance of Hippocratic Medicine in a district court in North Texas, claiming that this drug mifepristone, which is used for medication abortion, it's used in combination with another medication, was approved 21 years ago. There's 21 years of incontestable safety data about this drug. But if this judge issues an injunction, it could disappear from our ability to use it overnight. So just to go back to what's happened since those initial days when all of these states were open for abortion care. Now it's just New Mexico, Colorado, and Kansas. So, patients that were going to Oklahoma, Arkansas, Mississippi, Louisiana are no longer able to access care there. And this is a map just showing access to both procedural abortion and medication abortion. Medication abortion, which is a combination of two medications, has really filled the gap. That's a lot of the gap, and now accounts for over half of the abortions that take place in the U.S. So that's been great. And patients have been able to access medication abortion through telemedicine. They can do that in certain states, although it's outlawed in the restrictive states. But we suspect that patients are still, well, we know that patients are still getting them, and I'll show you in a second how they're doing it. So pregnant Texans had many concerns about going out of state, and you can imagine what they are. It's paying for travel, missing pay at work, navigating a new place, getting time off work, border checkpoints. That's really emerged as a real issue. We give advice to patients about where they can go, where they can avoid border checkpoints, childcare, and explaining their absence. Now, this was an interesting study that looked at Texans' interest in how to access abortion care after the fall of Roe. This obviously adds up to much more than 100%, because these were all the ways that patients were willing to access abortion. Getting pills through telehealth, going to Mexico to self-manage abortion care. If there were a ship off the coast of Texas, which we have some friends in the community that are working on potentially doing this, ordering pills online from another country. And we know that some of the gap in Texas, despite the fact that it's illegal, telemedicine abortion is illegal, that people are accessing pills online from another country, which is actually quite safe, as is self-managing abortion pills from Mexico, as long as reasonable instructions are given. And then, what are the reasons why clinicians have been unable to provide abortion care for all of these very complex conditions that they previously were able to offer abortion care for. So this is creating, tremendous risks. And as I mentioned, this goes beyond abortion care. What are the medical exceptions to abortion? We talked about miscarriage management. So we have seen multiple patients with miscarriages whose doctors are, disinclined to make the diagnosis, or have issues making the diagnosis, and they don't want to touch it because they're concerned about these laws where they could be, sued and criminalized. Ectopic pregnancy is another major concern. And ectopic pregnancy is one that grows outside the uterus. It's in the fallopian tube, or in a place where a pregnancy could not possibly could continue. And if there is still a fetal heartbeat, despite the fact that this is can become a medical emergency and still accounts for deaths due to pregnancy in the United States, doctors won't take care of it because they're worried they'll be accused of performing an abortion. So many other conditions that are driving driving providers not to be able to offer the care. This, I think, is a particularly challenging situation, and we've now seen several situations where a patient has an aggressive cancer that requires treatment, but the physician won't treat the cancer because of the pregnancy, but won't provide abortion care because it's not considered to be a medical emergency. And so this is threatening. This is threatening cancer care in situations like this, and also. The same clinics that do cervical cancer screening are often family planning clinics. So, patients are having trouble accessing, again, comprehensive reproductive health care, including cervical cancer screening, because of the abortion restrictions. And for that reason, you can see that this is from the cancer letter. Professional organizations across the House of Medicine, not just OBGYN or family medicine, cancer care, the American College of Cardiology has come out with a statement promoting legal abortion because of these really challenging patient situations where they can't get the care that they need because of these restrictions. This is just from like a couple of days ago on Yahoo News, that an Idaho hospital will stop delivering babies as doctors flee the state due to the abortion ban. So there were providers in this physicians in this hospital who basically said they could not practice in a state where they were not allowed to provide evidence-based care, where they would not be questioned for treating ectopic pregnancy, where they would not be questioned for providing miscarriage care, where they would not be questioned for being able to provide abortion care when that was the appropriate thing for their patient. So the physicians staffing these small rural hospitals are leaving because of this restrictive abortion ban in Idaho. And when we think about our own state and what's going on with maternal mortality and the closure of rural hospitals, we need every physician and provider that we can get to keep these rural hospitals open, because this ties not only into the unsafe abortion, but it also ties into maternal mortality. If patients have to travel very large distances to be able to get pregnancy care or care around the time of birth. Just having been at the Roundhouse not long ago, we hear over and over that physicians will not want to practice. This is from anti-abortion activists, that physicians will not want to practice in a state that does not restrict abortion care. And I think this kind of departure on the part of physicians shows how physicians really feel about not being able to provide evidence-based comprehensive reproductive health care. This is also from a very recent story. And this is the situation where a woman had her water break very early in pregnancy. And her doctor said, well, right now we just have to wait. We can't induce labor, even though you're 100% for sure going to lose your baby. So again, just some of these very challenging situations. Now, will outlawing abortion reduce the number of abortions? We did see the number of abortions decrease following Dobbs. So if you look, here's April. This is by month, national statistics. And here is August, post-Dobbs. In the long run, what we know from other countries is that outlawing abortion does not make a big dent in decreasing abortion, because when women and people want to access that abortion care, they will do just about anything to do it. We saw that on the previous slide. They'll do it by mail. They'll go to another country. They'll go to another state, despite all of the hardships involved. And they may even resort to unsafe care. So what really drives the abortion rate is actually contraception. So this was 90 in this study that asked Texans, would you consider other ways? 97%. That shows how inelastic the demand for abortion care is. And this is a New York Times article that showed that most women who are denied abortions by Texas law got them in another way. So these are abortions that used to be legal in Texas. These were requests for abortion pills, and these were patients who got abortion in nearby states. So the number of abortions has decreased, but a lot of people are accessing the care elsewhere. So if making abortion illegal doesn't work, then what? Well, it's actually contraception. And this is a piece from, I think a thought-provoking piece that this is a slippery slope. And, after abortion restrictions, what's likely to come next are restrictions on contraception. Again, what we know globally is that when you increase access to contraception, it's a direct correlation that the rate of abortion goes down. But but contraception is not safe. And this shows, in late September, Michigan's Republican Attorney General compared Plan B to fentanyl at a conference in Texas, suggesting the state should ban the pill. And since another Supreme Court decision, the Hobby Lobby case, which essentially allowed private corporations or people to decide what is and is not an abortifacient. In other words, saying, this doesn't prevent pregnancy, it causes an abortion. The field is open to create restrictions on contraception. I'll just say, in terms of Plan B, there is a lot of confusion about Plan B. Plan B is a hormone. It's a progestin hormone that acts in one way and one way only, and that is that it delays ovulation. So it does not act at the point of fertilization or at the point of implantation. It acts at the point of ovulation. So it really shows the sort of our willingness as a country to allow individuals to define what is and what is not a pregnancy preventive. So I think that this will be another battlefield, and one that we really need to think about and advocate for. And so what's happened in the wake of Dobbs is that physicians who have typically not been advocates, and I think have been uncomfortable with the role of being advocates, because we are trained, to be physicians, to take care of patients, but increasingly, physicians are going to need to and are stepping up to become advocates. Really proud of our department, who, as sort of as private citizens, many advocated in this session to be able to pass some of this reproductive health legislation that will allow us to continue to take care of our patients in New Mexico and our patients from Texas and our patients from other states. And if I would leave you with one sort of overriding thought, it's to consider when you vote and how you advocate that we are the stewards of our patients' care, that we do need to put our patients' interests above our own. And certainly in this setting, I think we're already seeing the harms that these laws are causing our patients, and we need to step up. And this is just a picture of our team from the some of our residents, some of our attendings, our fellows in the complex family planning division, and thank you very much.